Welcome everybody to our webinar today, which focuses on ethics support in responding to COVID-19, specifically the response of the Providence St. Joseph Health System and the efforts they took in treating the country's first confirmed COVID case at one of its medical centers in the Seattle area. Providence St. Joseph Health is a not-for-profit health system operating in 7 states and serves as the parent organization for more than 100,000 caregivers. The combined system includes 51 hospitals, 829 physician clinics, and other health, education, and social services across Washington, Oregon, California, Alaska, Montana, New Mexico, and Texas. Before I introduce today's panelists, I would like to begin with a prayer and let us reflect on the words of the Jesuit priest and philosopher, Pierre Teilhard de Chardin. Above all, trust in the slow work of God. We are quite naturally impatient in everything to reach the end without delay. We should like to skip the intermediate stages. We are impatient of being on the way to something unknown, something new. And yet it is the law of all progress that it is made by passing through some stages of instability, and that it may take a very long time. And so I think it is with you. Your ideas mature gradually. Let them grow. Let them shape themselves without undue haste. Don't try to force them on, as though you could be today what time, that is to say, grace and circumstances acting on your own goodwill, will make of you tomorrow. Only God could say what this new spirit gradually forming within you will be. Give our Lord the benefit of believing that his hand is leading you, and accept the anxiety of feeling yourself in suspense and incomplete. Today, we are pleased to be joined by panelists throughout the Providence St. Joseph Health System. First is Kevin Dirksen, who will moderate today's discussion with his colleagues. Kevin Dirksen is Senior Ethicist and Director of Ethics Education at Providence Center for Healthcare Ethics. In this role, he helps develop, manage, and teach ethics curricula to residents, nurses, and other clinical staff, participates in clinical rounds, provides ethics consultation, reviews and develops policies, and facilitates ethical discernments. Mark Carr is Regional Director of Ethics at Providence Health Alaska, where he is responsible for clinical consultation services, ethics education, and ethics-related policy matters for 5 hospitals across 6 Alaskan communities. Andrea Chatburn is a palliative care physician in Spokane, Washington, and serves as the Regional Director for Ethics for Providence St. Joseph Health in Eastern Washington and Western Montana. Nick Cochler is Endowed Chair in Applied Healthcare Ethics and Regional Director at Providence Center for Healthcare Ethics. His role as chair includes working with the internal medicine and family medicine residency programs for ethics education, as well as providing clinical and organizational ethics consultations throughout Oregon's regional ministries of Providence Health and Services. Karen Pavik-Zabinski is the Southern California Regional Director of Ethics for Providence St. Joseph Health, where she is responsible for ethics consultation, education, and programming throughout Southern California. Doyle Patterson is a clinical ethicist and healthcare educator at Covenant Health System, Texas and New Mexico region in Lubbock, Texas. And finally, Peter Cataldo is Senior Vice President for Theology and Ethics at Providence in Renton, Washington. Welcome to you all. I want to remind our listeners that if you have any questions during the presentation, go ahead and enter in the Q&A module on the bottom of your screen, and we will discuss them towards the end of the presentation. The other thing I would like to point out is that as registrants for this webinar, you'll be receiving a link to the recording we're making of this, as well as a link to the slides the presenters will show. So with that, I will turn it over to Kevin to begin the discussion.
Thank you, Brian. What a great way to begin our time together today. We want to extend our appreciation to Brian, Nate, and the team, as well as the Catholic Health Association more generally, for the invitation to share our experiences with you all. Our presentation will be a little more descriptive than some, telling a little bit of our story over the past several weeks. We hope to offer you an account of how we have been called into a response to COVID-19 at Providence, ranging from Alaska to Southern California and out east to Texas. Our experiences have not all been the same, in our respective regions, which may be similar to those joining from across the country. In our lightning round presentations, we hope to leave you with a keen sense of the important role of ethics in responding to a pandemic and a few questions to discuss with us toward the end of the hour. And with that, I will introduce our first speaker. Mark Carr is the Regional Director of Ethics in the Alaska region. Mark, take it away.
Thank you, Kevin. In terms of looking at the slides, I may need to pull mine up here. Are you able to advance them?
We're having a little bit of trouble with the slides, Mark. We'll try to get those advanced as possible.
All right. Well, I'll work from mine if I need to. Otherwise, thanks for that introduction. I want to give people a sense of the area because it is difficult to, truly difficult to imagine the distance. 6 communities in Alaska. Providence, Alaska serves in only 6 of our communities, but 2 of those communities are a 7-hour drive from each other. One of the communities is a flight to Kodiak Island, and it is routinely the case that once you get to Kodiak, you don't get back home. We're the largest private employer in the state of Alaska, and all things medical eventually end up here within the state, and we're the main hub in terms of transitioning then to Seattle and wherever else an emergent situation might need to head to. So rural healthcare and interaction with the other healthcare systems is particularly challenging, and that became one of the unique elements of this particular event. Go ahead to the next slide, Kevin. Yeah, so some of the barriers that arose were a surprise to me. There is a perception among other providers and facilities about my work that the work of a Catholic healthcare system ethicist is parochial. In other words, I'm supposed to care for things that Catholics care about only, and most of the public is not fully aware what that means. There was a broad and I think a continuing misperception that the only thing we care about is women's reproductive health. So that perception needed to be adjusted and is something I was mindful of. Others felt that my work was proprietary. In other words, I work for the corporation. I don't work for the local community. I don't work for the people who we care for. And I think that was a barrier as well. A similar perception, although from a different direction from those within our own hallways, where it is oftentimes maybe subtly sensed, and maybe I'm overly sensitive to it, but the idea being that it's never appropriate to talk to competition regarding our work, never share policies, all of our business practices, and so on and so forth. So I've been really tuned into this sense of cooperation as opposed to competition, particularly with regard to situations of public health emergency. Also then connecting to a large corporate healthcare system has both strengths and potential weaknesses. So there's an incredible strength and depth of corporate resources in so many ways, and I could spend a lot of time describing those. On the other hand, sometimes that cuts both ways, and locally it might hold us back from cooperating and integrating as fully as we might. For instance, one other healthcare system that is here in Alaska was noting that despite our triage conversations, her system had identified how they were supposed to respond to triage issues and had a fully worked out scenario that she was not allowed to deviate from, regardless of local things. And so that was one of the difficulties. Go ahead, Kevin, to the next slide. leading out by happenstance. So simply by virtue of the fact that we had a conversation, it became the conversation. One of the realities is that our internal people started to talk, but it included physician groups that are contracted with the hospital, but they also hold contracts with other hospitals. And so other hospitals' personnel started to jump on the phone call as well. And so 6 people turned into a statewide conversation across dozens of communities with over 40 people all across the state. One of the quick things that turned up was, despite the articles, despite the material to help make decisions in terms of the SOFA score and the various ways to triage patients, there was a felt need to have a more fine-toothed, more detailed document that would allow the scoring mechanisms. And several of our physicians in the group went to work trying to create something that felt to them a little more useful in the moment. Again, unique to Alaska, it's really important that I highlight some of the Alaska Indigenous history and context. For instance, in triage work, when there's a tiebreaker, there's, of course, a lot of discussion about who might be privileged and for what reasons. And of course, healthcare personnel have been said to be privileged or preferred in a tiebreaker, but also younger persons, not simply by age, but age cohort and so on. As you know, triage is a complex work, but younger people were said to be privileged in some ways in tiebreakers. Well, some of the tribal cultures in Alaska do not have that same intuitive approach. They would prefer, and they would likely give a preference to older persons in their community over younger persons. There's a sense of maintaining the tradition, maintaining the history of the people by caring for their older people. It's also very important to highlight the fact that the Spanish flu hit Alaskan villages and indigenous people extraordinarily hard. These links in the slides go to then stories about the Spanish flu. And just imagine, in 5 days in a village of 80 people, 72 were dead. Similarly, in Bristol Bay. And so some of those memories are very fresh. And this time of year, we're actually gearing up for our commercial fishing season. So many of the bush communities, as we refer to them, are very nervous right now. Finally, the Alaskan economy has 3 sources of income. There's no personal income tax here: tourism, seafood, and oil. And so economically, these 3 things depend on people and being here to generate that kind of income. So those are the unique elements of leading out in Alaska during this time. I'll send it back to Kevin and appreciate your time.
Thank you, Mark. Really appreciate you sharing with us some of your experiences up in Alaska, and look forward to folks' questions in the Q&A, which we'll hold toward the end. And with that, I'd like to introduce my colleague, Andy Chatburn, who is Regional Director of Ethics in the Eastern Washington and Montana region of Providence. So with that, Andy, we'll try to get the slides advanced.
Thanks, Kevin. Within our region, the Sisters of Providence have really been steadfast leaders in healthcare in Washington, Montana for over 140 years, with 5 of our current 17 acute care hospitals in the region continuously caring for our communities for over 130 years. The region itself constitutes 10 Catholic ministries with 7 mission partners that constitute the Washington, Montana region, as well as Swedish. As a region, this represents over 4,000 acute care beds. With that, it additionally has an entirely standalone rehabilitation hospital that receives referrals from our partners as well as our other Providence hospitals throughout the system. It has robust home health, hospice facilities, long-term care facilities, low-income senior housing, and adult day health, and a developing PACE program. So the first US COVID-19 patient was admitted to Providence Regional Medical Center Everett in Washington on January 20th. Triage testing and adequate PPE have been some of the most difficult aspects that we've been facing. Providence Sacred Heart Medical Center and Children's Hospital was designated incidentally in 2015 as the US Department of Health and Human Services and CDC Region 10 treatment centers for special pathogens. And because of that, 4 patients who were asymptomatic but were COVID positive arrived at Sacred Heart Medical Center on February 20th from the Diamond Princess cruise ship to be cared for in this special pathogens unit as the pandemic was unfolding and evolving in the early days. With this, Providence has been practicing and been donning and doffing for the past 5 years, 5 years and more, practicing and collaborating with that. But never did we expect that we would receive a pandemic similar to this. I think everyone was prepared for Ebola, and that was the genesis of the development of that special pathogens unit. Next slide, Kevin. One of the biggest exercises that we've done and collaborations has been a collaboration with our health officers, Washington State Vice Admiral Bono, in collaboration with our individual hospital incident commands, the COOs, as well as Northwest Health Resource Network, which is part of the Department of Health response, and the individual county health officer responses. What became really evident early on with their collaboration was that in a pandemic, solidarity had to rule the day. Without solidarity and without a sense of being able to share resources, ICU beds, transfers, ventilators, if needed, across organizational lines within a geographic area. And then we would not be able to really clearly know what our capability of stretch within a contingency standard of care would be. With that, there was a lot of discussion early on around when would a hospital tip over in that spectrum of crisis standards of care into the crisis category from a contingency or a surge. From that, it became very clear early on that if a hospital were to move towards crisis, that they really needed to be collaborating with all of their other former competitors and that every hospital in that county area or multi-county area, or even really Western Washington East versus Eastern Washington, every hospital would need to move towards crisis together, because without moving towards crisis together and without that collaboration, we weren't able to serve our communities, and serving our communities became the top priority. And I think that's one of the most beautiful things that developed. The other piece to that collaboration was that it became clear that every one of the hospitals within the Washington State area, and then Montana collaborating with the Montana State groups, needed to have the same criteria around ICU admissions, the same criteria around triage teams. If we got to a point where crisis was declared and we were needing to make decisions around who was placed on a ventilator and who was not. Those triage teams were developed with a chief medical officer, 2 to 3 senior clinicians who were not bedside providers, an ethicist and command center member, as well as someone for administrative data support to really make those decisions if needed, as well as regional oversight committees and support committees for what to do if there's a disagreement, what to do if there's a tiebreaker. Mark mentioned tiebreakers in Washington State. One of the emerging priorities around tiebreakers became the need to have some randomization if there were two patients who are clinically equivalent. Next slide. One of the things that we also realized was that because of the panic and the urgency that arose, we had two different phenomenons. One was providers and teams that were saying, "Gosh, we want to have the highest quality care for these patients. This is what I do," and a pride in that work that aligns with the duty to care, and wanting to really stay in conventional standard of care within if you'll see here from green to red, we have conventional, contingency, and crisis, which is our spectrum of crisis standards of care, and individuals really wanting to stay within that conventional approach around shared decision making, informed consent, assent only in extreme futility. So we had both a dichotomy between individuals saying, "Gosh, our standard of care is the same across every context," and which we would crisis standards of care work would suggest that we're not, and then a group of individuals saying, "Gosh, we're in a crisis, in panic," and we really had to slow folks down and say, "No, we're in this middle ground, this liminal space called contingency. We're in this shift between individual autonomy and population-based decisions, and we need to create space for discerning where we are. And throughout all of this, we need to focus on goals of care, patient preferences, and identifying surrogate decision makers." That's what's the same between all three of these, and really look at what's a proportionate response within that private, sacred patient-provider encounter. And what does that look like in this new strange place called contingency where we've never been before? Kevin, back to you.
Hey, thank you, Andy. We really appreciate that account. All eyes were on Washington State there at the beginning, and we appreciate all that you and your colleagues did to share with us some of the learnings that you've done today. And with that, I'd like to introduce my colleague, Nick Cockler, who serves as Endowed Chair in Applied Healthcare Ethics and is Regional Director of the Providence Center for Healthcare Ethics in Oregon. So Nick, take it away.
Thank you, Kevin. Good afternoon or good morning, depending on where you are. I wanted to start off by giving some context to our region here in Oregon. We have 8 hospitals, 8 acute care facilities, including 1 regional referral center for ARDS, which is significant for responding to COVID. We have 4 teaching hospitals, 3 of which are in the Portland metro area, and critical access hospitals. Like Mark in Alaska, we are the largest private employer in the state. We have over 20,000 caregivers. Over each year, we have approximately 70,000 hospital admissions. Over 9,000 babies are born in Providence Ministries. That's the most in the state. We have approximately 22,000 inpatient surgeries, dozens and dozens of clinics, both in terms of primary and specialty care clinics, with over 2 million visits a year. And we also have home services, home hospice, and a PACE program. And our health plan is also based here in Oregon. Next slide, please. Our story actually begins several years ago with my predecessor, Father John Toohey, who was the first person to hold the endowed chair that I hold, who is the principal ethics architect for the state of Oregon's response to public health emergencies. And he developed this matrix for ethical decision-making, which actually appeared in the Health Progress publication in May and June of 2007. This matrix is not a linear algorithm. This is a way of representing what we think about when we address ethical decisions or ethical questions in a pandemic or a natural disaster or other mass casualty event. The matrix is based on 3 fundamental values. As Andy had mentioned, social solidarity is one of the primary values that drives our response, professionalism, and justice. Within each of these, the matrix identifies different characteristics of those three values depicted here within the circle. And outside of the circle are various ethical principles or norms that inform our ethical decision-making and our response. So duty to plan and having a playbook or a framework to enter into a conversation around how do we think about duty to care in a setting of scarce PPE, or how do we think about establishing a common set of triage protocols, or how do we ensure that we account for diversity, equity, and inclusion in our response. So this is, again, a tool that we have been using throughout this particular pandemic, but it's also something that we used in the Ebola outbreak and in the prior outbreaks in terms of SARS, H1N1, and Ebola. Next slide, please. So I want to draw your attention to that upper circle, upper oval. We entered this pandemic with the Oregon Crisis Care Guidance document from the Oregon Health Authority. This was the basic framework that informed all of the hospitals and healthcare organizations in the state of Oregon. And very early on, my colleague Kevin, who is part of the ethics work group of this guidance document, was asked to articulate the ethical dimensions to the question of duty to care in the setting of scarce PPE. And so that was one of the earlier work streams that we had to do, and that might be highlighted in the next tab over. From that began a very iterative and organic process where we had to broker all of the different threads of our connection between external parties with the Oregon Health Authority to internal system leadership and our collaboration with Peter and my colleagues on this webinar. We developed the internal guidance for our system, and that is highlighted over on the left with the Ethics Leadership Council, which we all of us on this call comprise. After that, it became clear that we needed to work also locally, and so the local public health official, Dr. Jennifer Vines, reached out to the ethics leaders in the Portland metro area to help develop a common set of principles that would inform our triage protocol. As Andy had mentioned, we were intending as a healthcare organization with others in the Portland metro area to coordinate our resources so that not any one of us alone would be entering a crisis phase to allocate scarce resources, but we would be doing it as a community. Again, that value of social solidarity driving that. So we collaborated very extensively, and it continues to this day, on an iterative process of developing that triage protocol in dialogue with our internal guidance, in dialogue with the statewide guidance, that has resulted in a tool that is now in its 4th version, and I believe it's been been adopted or accepted at 10 healthcare systems representing about 36 hospitals statewide. From that, we've also had to operationalize that triage protocol internally, and so that led us to draft a triage team charter. Again, there would be regional teams, but also more local health system specific teams that we've had to think about staffing and rotating on and off, and how do we think through that, much of which has already been said in terms of the similar parameters. Our work had also continued, our normal work had also continued with ethics consultation, teaching the medical residents, so giving noon conferences, informing our ethics committees with what's going on. We partnered with our system library resources to develop an internal intranet page on ethics resources. And we've also continued our work at the system level with answering questions broadly around COVID research and how do we think about transferring patients into and out of hospitals for the purpose of enrolling in a study, and helping to contribute to our system-wide playbook on a pandemic response under the Emergency Operations Council. On the horizon, next slide, we are anticipating another body of work around, excuse me, prudent expansion of care. What, when, where, and how. You know, the most immediate has been the reintroduction of elective or discretionary procedures. We are going to be tapped to respond to the social and financial impact of the pandemic. How do we adapt as a healthcare organization? How do we incorporate mission and values discernments into that process? That's both locally and system-wide. Big data and mapping are certainly going to be perennial questions going forward. And new ways of carrying out our own programming and services within the center will continue to have to adapt with social distancing, et cetera, being in place for some time. Thank you. Kevin, back to you.
Thanks, Nick. Really appreciate you taking time to summarize some of the work we've been up to here in Oregon, and can anticipate folks will have plenty of comments and questions for the close of our hour today. And with that, I'd like to shift to Southern California. Karen Paddock-Zabinski is our Regional Director of Ethics down in Southern California. And if I can get the slide advanced, we'll get you underway, Karen. So thank you.
Wonderful, thanks, Kevin. And again, good morning and good afternoon to all of my fellow colleagues across the nation. Next slide, please. I wanted to give you a little bit of a visual representation of what Providence St. Joseph Health locations in the communities that we serve here in Los Angeles, in San Bernardino, and in the Orange County. So in total, there are over 8.8 million people that live in these communities that are located 50 miles north, 110 miles east, 30 miles northwest, and about 58 miles south of LAX. So you can see it's quite a very large territory. Within this section, we have 13 acute ministries, a 56-bed long-term care center, 2 separate subacute centers, one up in Mission Hills in our San Fernando Valley, and one down in the South Bay. We also have a high school. We have behavioral health, 3 behavioral health inpatient units, a child care center, Providence Trinity Hospice that cares not only for adult but also pediatric patients, several cancer centers, and like many of you, also many freestanding outpatient same-day surgery centers. Next slide, please. So in the month of February, like many of you across our system nation, we began to hear about data coming from parts of the world about a virus that affects individuals very quickly with a potentially devastating trajectory pattern. I recall reaching out to a few of you on this call to learn what you were hearing, what you were reading, what steps you may be contemplating as you were developing your own response to this pandemic. Interesting was also at the same time that I was asked to present, talk to a parish community about church teachings and healthcare decision-making, especially at the end of one's life. And little did I know how important that would become, as many of our parishioners receive their medical care at one of our ministries in that particular community of Santa Monica. My colleagues and I soon published the first version of our ethical guiding document that Peter's going to talk a little bit more about later. And from these conversations, I identified 3 major strategies for the work that I'm involved in as the Regional Director of Ethics for Southern California, moving from conventional work in healthcare to that contingency phase while also preparing for the possibility of a full crisis. These included education, programming, transparency and communication, and being a resource to the greater ethics community that we serve. So each of our respective regions, we have set up what's called a Regional Ethics Council. And here in Southern California, my members are from our local ministry ethics committees that include the chairs, the co-chairs, and the mission leader. We've had many conversations around reviewing specific care policies to ensure that we were all up to date, especially on the process of treatment decisions for patients who may lack decisional capacity and do not have a legal decision maker. Once the system ethics guiding documents were written, it was very important at that time to work with my colleagues across the region, especially at the regional council level, to take these resource tools and educate our core leaders at each of the ministries. including our operational folks. So like many of your systems, our senior leaders at that system level established daily calls as soon as Providence received the first patient that had the diagnosis of COVID-19 in the state of Washington. These calls were focusing on operational specifics of the responses to scarce resources, which in turn were discussed more in detail at the regional level, where we initiated weekly calls with all of our CMOs, our CNOs, our quality folks, and many others who wanted to ensure that they heard the voice of ethics on these calls. I was participating to provide support, provide clarification and guidance as we were looking at to develop policies and possibly new processes. One of the most important tactics to support an ethics educational program was a response to COVID-19, was in providing guidance in understanding the who, the how, and the when in developing triage teams at each one of our local ministries. Peter is again going to speak to a little bit more about the pandemic playbook, but I wanted just to bring this up because it outlines different levels of triage, who the people would be involved, which includes someone from ethics at each one of our ministries. The key to success would be in holding mock triage case studies. So the teams would be prepared in an event that their ministry needed to move from a contingency phase to a full crisis. So I worked with many of the teams in order to facilitate these mock case studies. First and foremost, I think really to alleviate as much anxiety and moral distress that our care providers would anticipate that they would be feeling. My second strategy had to do with ensuring transparency and communication. System calls, regional calls, articles being downloaded, memos sent, the media, et cetera, had all the potential to create a lot of information overload, which could lead to more distress for our care providers. So it was and continues to be very important to have a dedicated resource for some of that information, especially for our physicians, for our care providers, and for regional leadership. I worked very closely with our CNOs, as I said, our risk managers, our quality managers. It's important here to recognize that physicians in California by law are not employed by the hospital unless the system has a dedicated health plan. So many continue to work not only at our medical centers, our ministries, but also in other hospitals across the communities that we serve. So it's very important for me to reach over that table or reach over that pond to really look toward my ethics colleagues at UCLA, USC, Cedars, Kaiser, especially since these institutions were, as I said, in our community. We wanted to be able to share the best practices to support our physician engagement and community confidence. So my third strategy was really, again, and continues to be looking to be a pivotal resource to all of our folks here. I've been working with the Alliance for Catholic Healthcare, which is an organization in California that we work closely with our bishops, with the California Medical Association, and the Federal Correctional System. Next slide. So I think what I just wanted to recap, some of the lessons and the key takeaways that I've had. First and foremost, collaboration with my mission colleagues and with all the core leaders, again, to ensure that there's transparency and communication and appropriate education. What we all recognize is what is legal may not be ethical, and what ethical may not be legal. But what's most important to emphasize, and I've been really working with all of our core leaders on this, is our commitment to our mission and our values and our ethics will never change. Situations may change, but our commitments will never change. So thanks very much, and I'll let Kevin take over.
Karen, thanks so much for presenting some of the hard work that you and others have been engaged in Southern California. We appreciate your account and again, look forward to folks' questions at the end of the hour about your presentation. And with that, I'd like to introduce Doyle Patterson, who serves as clinical ethicist in the Texas-New Mexico region. Doyle, take it away.
Thank you, Kevin. Good morning, good afternoon to all of you who have joined us. By way of introduction, regarding the story coming from Texas, New Mexico, I want to quote from the General Introduction, 6th edition of the Ethical Religious Directives for the Catholic Healthcare Services, For the Christian, our encounter with suffering and death can take on a positive and distinctive meaning through the redemptive power of Jesus' suffering and death. This truth does not lessen the pain and fear, but gives confidence and grace for bearing suffering rather than being overwhelmed by it. The church seeks to ensure that the service offered in the past will continue in the future. Next slide, please. As I look at our part of the story, I want to talk about congregant residential facilities and the impact that they have had on hospital emergency departments. Just a snapshot of the Texas-New Mexico region. We are made up of 25 counties, 60,000 square miles. The population that we serve is 1.2 million. The largest community is Lubbock, Texas, with a population of just a little over 301,000 people. That says that just a little under 1% of our population are in beds of nursing homes and assisted living facilities. As we are dealing with the pandemic, we also want to look at our direction as we move forward, not just serving within the walls of our acute hospitals, but also beyond into the communities of the region that we serve. One of the things that I really like on this term, congregant residential facilities, nursing home is so much easier to say than congregant residential facility, but this term gives me a visual. The residents who live in these facilities, they can't self-distance, they can't social distance. They are dependent upon other people for their protection and their care. And we who are strong must provide that protection and that care for them. And I believe it becomes part of who we are to provide. The elderly, the frail, the vulnerable residents of these facilities are the population that's been hit the hardest by this pandemic. Next slide, please. In April of 2020, in Lubbock, Texas, 51% of the pandemic cases were associated with nursing homes. April the 10th, in Lubbock, 13 deaths. In Lubbock, 12 of them were associated with nursing homes. On the 22nd of April, 39 deaths in Lubbock, Texas attributed to the pandemic. 35 of the 39 were associated with Lubbock nursing homes. These people who, fragile and vulnerable, were hit extremely hard. One of the questions that we were faced had to do with nursing homes transporting more than usual residents to the emergency departments. Many of these had a Texas out of hospital, do not resuscitate. This raised red flags for us. Were the wishes of these residents being ignored? So our approach, and the question was given to us to have conversation and see what was taking place in the nursing homes. And our approach was, how can we help these facilities who have limited resources and are overloading the hospital emergency departments with out-of-hospital DNRs? Next slide, please. This gave us an opportunity to have conversation with administrators who were directing and administrating these nursing homes. There was one nursing home in particular that we were asked to have conversation with as they were transporting their residents to the emergency department. Mid-April, they had approximately 55 residents. 39 of those were tested positive, and 10 deaths had occurred regarding the pandemic. our approach was in our conversation, how can we help you? You have limited resources. We recognize that. Knowing that their transporting of these patients were having an effect upon our EDs, overloading our resources. And we wanted to address the issue of how can we help you in this situation that you find yourselves in. Our conversation became with the director of nursing and the administrator. There were two people from their corporate system, two physicians, myself and the medical director of the city's public health, and the director. Were on the call as we talked about possibilities that we could do involving education, opening the doors for discussion on advanced directives and goals of care, not just with the residents, but also with their families. We wanted and want to address the issue of how can we help these residents know what their goals of care are, what are their wishes, how can we help them in this area, and with this theme that the most appropriate care provided at the most appropriate location. If it needs to be in the hospital, we'll work toward that end. If it needs to be in the nursing home, let us work toward that end and help the facilities of our communities, not just Lubbock, but reaching out into the region and helping as we work together as a collaborative team in serving the most vulnerable, the elderly, those who need our help. Thank you so much.
Thank you, Doyle. We really appreciate you highlighting some of what you've been up to in Lubbock and throughout the Texas-New Mexico region, with particular focus on what's going on in nursing homes. I know many of our folks have questions about nursing homes and the effect of COVID-19, some of which we might be able to expand a little bit upon in the Q&A. Our last presenter, I'd like to introduce Peter Cataldo, who is our Senior Vice President of Theology and Ethics here at Providence. So, Peter, would you take it away for a system perspective?
Yes, thank you very much. And I want to thank our ethics team for their tremendous work during this whole episode of the pandemic. They really have performed in a way that is a model for others. So if we could go to the next slide, please. I just want to spend a couple of minutes talking about how we coordinated the system response to the ethics needs in this pandemic. And this came largely from the Ethics Leadership Council for our system. The Ethics Leadership Council is composed of all of the full-time professional ethicists within our system, those who are presenting here today. We early on adopted weekly COVID-19 updates to address issues both within our regions and also system-wide. We also met regularly and continue to meet over special issues such as issues around the transfer acceptance of COVID-19 patients for study protocols, issues around DNR orders, healthcare worker prioritization, and other particular kinds of issues. Early on, we, as a Ethics Leadership Council, addressed time-sensitive needs, and early on, that required us to develop a basic ethical framework for our caregivers and decision makers across the system within the context of allocation of scarce resources. And so at that earlier period, we addressed issues like prejudice and bias, that was being experienced, issues around duty to care, and severe PPE shortages. We then turned our work to developing a comprehensive guidance for the system, and we needed to develop a more comprehensive guidance and approach that included an ethics framework, a triage team guidance, and clinical triage protocols, all in one approach. This became the task of an interdisciplinary group in which ethics was a critical part to develop this system approach. We also wanted to develop an approach that would balance, on the one hand, system consistency in our response to the pandemic, but also, on the other hand, recognize regional subsidiarity. And so we finally achieved this balance, I believe, by developing a guide that allows for the regional development of guidelines using respective state guidelines, but also includes an interdisciplinary system review of regional guidelines. And this review, of course, involves ethics as well as legal, risk, and clinical. And then finally, we, as an Ethics Leadership Council, worked on mapping out our ethics support for conventional, contingency, and crisis operations in the Providence St. Joseph Health Pandemic Playbook. This was a detailed guidance on ethics support in all three of these phases, and provides very helpful guidance both for the current situation and into the future. So our Ethics Leadership Council really led the way in providing ethics support in different areas, responding to our ethics needs across the system. Thank you, Kevin.
Thank you, Peter. We appreciate you taking an opportunity to share with us some of your coordination of the Ethics Leadership Council at the system level, and appreciate all the presenters. I want to thank you for sharing with us your perspectives from the regions, and we look forward to jumping into a few questions. So the first that we've received from Chaplain Stephen Doyle asks, were any of the presenters involved in the process of trying to determine who gets a ventilator if there were more patients than ventilators? And since I'm off mic and have the camera on right now, I'll say that we have definitely been involved in some of that work in Oregon, and our other ethics colleagues can speak to that in other parts of the system. You know, one thing I would like to highlight is the importance of this work, not just if there were to be a surge or a crisis triage level of response required, too many patients, not enough acute critical care resources, but what message these documents have communicated to folks about the value of life, about how we think about a scarce resource allocation in not only the worst of times, but also the best of times. We've really been listening a lot to folks in diversity, equity, and inclusion, as well as our disability communities, that have helped us to think about what do these documents mean, even if they never see the light of day in informing the work of triage teams, but communicate a message nonetheless. With that, we've also had another question from Joan Crabtree around aspects related to the important work of spiritual health. And one of the questions that we had put in the queue before the webinar even began was related to caring for doctors, nurses, and caregivers. Karen in Southern California, I'm hoping that you might be able to take that, sharing a little bit about how do we think about some of the moral distress dilemmas that we've been seeing either within Providence or in other parts of the country, and what specifically might you offer to Joan around spiritual health on this?
Joan, first of all, thank you for the question. I think it's really important. I talked a little bit about moral distress, and I think anytime that we as healthcare providers, as ethicists, as spiritual care, whatever, can do to help alleviate that. Sometimes it is through education. Sometimes it's opportunities to meet together and to discern, to talk about your feelings. Sometimes it is developing specific programs or specific policies. I know here in Southern California, like many of my colleagues in the region, our human resource folks have been very collaborative in helping to establish concrete programs that our physicians, our staffs, and all of our care providers would be able to tap into in order to fill themselves up so that they can keep coming back every single day. But I think the last thing I just want to say is, my experience with working with the triage teams in these mock trials, these mock scenarios, again, has able to tease out the distress that they would have anticipated that they would feel, and how can they process this outside of being in a crisis mode.
Thanks so much, Karen. Really appreciate your response there. I'd like to shift to a couple of questions that we've received in response to the conversation around long-term care and nursing homes. Specifically, Doyle, wondering if you have any thoughts around some particular aspects that have maybe come up in other places around questions around reporting of numbers regarding how do numbers of positive COVID-19 patients or staff affect the reputation of the nursing home, or have other perhaps deleterious effects to the public health concern, which is motivating that kind of reporting. And secondly, anything rise up in terms of conversations around HIPAA and how specifically patient privacy or confidentiality affected the ways nursing homes were able to liaise with the public or family members through some of your work in Texas?
This area of residential facilities is expansive. It's not narrow, it's broad. And as I look at this, I see that it's not an us versus them, that we work collaboratively to provide assistance and care for the residents. And I caught myself one day calling them patients, but actually these people are residents, and most of them, it's their last residential area where they will live. And how can we collaboratively provide care? And nursing homes are in the news big time now with all of the deaths that are occurring across the nation. As I think about how we can help, nurses, maybe by virtue of fact, maybe not, I get a bad rap from time to time regarding deaths. They don't want residents dying in their home. Is it a marketing, whatever that may be. And to me, that should not necessarily be the issue, but here is a population that is highly vulnerable. The elderly, how can we provide help, care, protection by providing care, help, and assistance for those who are providing care for them in the nursing homes. I think it's a situation that's bigger than any of us individually and probably collectively, but can we ignore it?
Thanks, Doyle. Maybe the last question, since we're at time, we can shift to Magdalene Sebastian asks a specific question around policies for supporting religious groups who have distinct needs in terms of caring for the body after death. Really important question, and maybe if I could, moderator's discretion, broaden that to any considerations around how we do good end of life, good whole person care in the setting of folks that have died as associated with COVID-19 or other causes in the hospital, yet affected by visitation policies and other ways that healthcare is demanded to be altered during a pandemic. Andy, in Eastern Washington and Montana, what have you seen around visitation policies or any specific aspects related to cultural or religious accommodation to ways of understanding and responding to death?
Sure. In order to balance the protection of the community, the local and the state stay home, stay safe mandates, as well as really make sure that we're protecting our caregivers and minimizing PPE use, because PPE, ironically, PPE was our most scarce resource. It wasn't the ventilator or necessarily staffing. It was PPE, and so because of the needing to protect caregivers, protect staff, protect patients from the public, and protect the public from them, potentially because of the asymptomatic nature of much of the spread, visitation policies have regretfully, it's been a deep sadness, but a necessary population decision to really have a no visitor policy, with exception on a case basis for patients who are imminently dying, having two people be at their bedside. A child, of course, needs to have at least one parent at the bedside, and a delivering mother, as well as someone who is being discharged, needs to be able to have someone to have teaching for their successful discharge. And so that was the limitation around our visitation. With that, at each step of the way, we're trying to be as accommodating and as creative as possible for individual death practices. But it's been difficult, and it has been a deep sadness, and we're holding that, and collaborating with our nursing home, or excuse me, funeral homes, to be able to provide that. But in some instances, being at home has allowed encouraging patients to discharge home for care at the end of life might provide the best possible individualized family-based preferences, which is part of what the work of home hospice does. But it puts the burden on the family, and there's no easy way around that.
Mm-hmm.
Thank you very much for that answer, Andy. That obviously could be a host of more conversation in itself, a sort of focus on what questions, what dilemmas are occurring around how do we respect the practice of recognizing mourning, loss and death in COVID-19. But thank you for that answer. One of the questions that we've received before the start of the presentation relates to what does the future of healthcare look like due to COVID-19? I know there are a lot of questions now around how does healthcare look after this first wave may be coming to a close in some parts of our countries, and prepping for future waves, caring for patients like we used to before alongside a COVID-19 patient population. Nick, we practice in a very integrated climate in Oregon with a health plan, with a very robust outpatient ambulatory care network. Maybe can you take a first stab? And Peter, if you have anything to add on what might healthcare look like post-COVID-19?
Thanks, Kevin. Yeah, it's a very important question, and it's becoming more and more present to us as time goes on. I think one of the earlier observations in the midst of the pandemic and our response was how it has accelerated some of the things that we had been thinking about doing, such as integrating digital access to care and telehealth. This pandemic seems to have accelerated that body of work, and it is anticipated that some of that will continue into the future. But given the profound social and financial impact of the pandemic, both in the near term and the long term, a lot remains to be seen about what exactly that will look like, and no one has a very clear crystal ball. But one of the things that we are proud of is that our leadership has been very keen on ensuring that our mission and values and our ethical principles are infused into the decision-making process from the system level down through the local ministries. And so fortunately, we have a robust framework for discernments, and yet we will also need to figure out how to be proactive and adapt given the enormity of the response that's going to be required, and the really the evolution of healthcare into the next iteration. So, some of those particular questions are, as I said, are about telehealth, or how we use big data and a population health lens, and what does patient privacy look like? How does a public health emergency change that? We are looking internally at the center, about, again, expanding our digital education and distance learning and asynchronous learning, just to give you a sense. And, some of this is being pushed out into the fall, that, physical distancing is probably going to be with us for some time. So what does medical grand rounds look like going forward? And we have 4 funded lectureships. We have a robust core program, as some of my colleagues do as well. And so what does that all look like in the future? And how do we uphold our value of excellence while at the same time adapting to these new circumstances? So a whole array of questions and issues that we are currently and will for the foreseeable future be sorting through. But I'm sure Peter has other things to add from a system perspective.
Yeah, those are all, I think, really important observations that Nick has shared, and I think that with respect to the use of telehealth, it has been accelerated within our system as well as systems across the country, and who knows, if telehealth becomes widespread at a high level, we may not need as many urgent care centers across the country. That would be a big change. Our colleagues, we have discussed the point that this pandemic has been an occasion for health systems to be more collaborative. And hopefully that collaboration will continue into the future rather than what is sometimes more competition. Certainly, we can talk about short-term effects as well as long-term effects from this pandemic. Health systems across the country are looking at trying to recover financially. That is going to have a lasting impact, that recovery process and the effects from the response of healthcare to COVID-19. So, it is going to be a dynamic process for the model of healthcare moving forward.
Thank you, Peter and Nick. Appreciate you taking a stab at otherwise a pretty difficult question, looking into the crystal ball, if you will. But I know a lot of us are thinking hard about what that means, whether we do ethics or are connected to mission or are clinical or operational leaders in Catholic healthcare. Mark, I know that you're not immune to these questions up in Alaska, and you started us off at the top of the hour with a presentation about some of what you've been up to in Alaska. Can you highlight a little bit for us maybe a particular difficult scenario that you've been looped into in this COVID-19 world we're now practicing in? Can you share with us a little bit about one of the more difficult questions that has come your way since this pandemic has begun?
I might point to the nature of how our state manages itself. With multiple healthcare systems and a community and a physical footprint that is as large as ours, How does the state manage that appropriately? Alaskans are particularly independent, and I know most states across the country say that about themselves on a regular basis. You can just add steroids to whatever kind of individualism you might experience in your own area. Alaskans are extraordinarily individualistic, and the frontier mentality does reign. Nonetheless, when the state is asked to manage and somehow be involved in a proclamation of public health emergency, and when resources are scarce, there has been literally a moment by moment, a real-time decision-making at the state, because there has been no preparation for this sort of event. At the beginning, a special group at the state level adapted the Minnesota Department of Health document and made it our own overnight because we had nothing. It's not as if we don't know how to do this. It's just that we don't care to organize ourselves in a fashion typical elsewhere. So that kind of independence, just a brief illustration, the very first time I voted, and I'm getting older, mind you, but the very first time I voted in 1978, I voted yes to the ballot measure of whether or not Alaska should secede from the United States. So that kind of mindset doesn't work well when you have to manage your entire population in some kind of cohesive fashion. That would be, ultimately the biggest point of uniqueness here, Kevin. Thanks for the question.
Well, thank you, Mark, and thanks to all our presenters and to CHA once more for being able to share our perspective a little bit today. An ethics webinar in terms of clinical and organizational ethics storytelling is a unique platform to share with you all today, but we hope that those who have joined have been able to learn a little bit about how we've confronted some of these questions and maybe start to inspire some ability for you all to start sharing with us and others about what we've learned throughout all of this, so that hopefully our experiences in COVID-19 aren't but a historical antecedent, but are a way of learning how we're going to do healthcare better in the future and respond to the next public health emergency as best we can. So with that, from the Providence side, we'd just again like to offer our thanks, and to our host, CHA, and to Blue Sky, any closing remarks or comments for the group?
Absolutely. Thank you. And with that, on behalf of the Catholic Health Association and Providence St. Joseph Health, I would like to thank you for participating in today's event. A recording will be sent in an email and will also be posted to CHA's website at www.chausa.org/coronavirus. This concludes today's program. Thank you and have a great day.